you. I'd like to invite Christopher to words.
Okay, thank you, Cinzia, for the introduction and for the invitation to this great conference. I was invited to present something on the current use of PREMs oncology care in the EU, and as you see, I changed the title to Europe because one of the examples that I'm going to show is from England, and England is no longer part of the EU, as we know. So I will present this, and I will also give a lot of opinions that are not necessarily based on evidence, but stem from my, say, experience over the last 20 years or so. The main COI that I might have is that I'm a consultant for the German Institute for Quality and Transparency in Healthcare, and their work is something that is among those projects that I'm presenting. This is what I'm going to present. Some words on the background, on my employer, the German Cancer Society, and on me, on PREMs, a definition. We will hear others today, I'm sure, what they are good for from my opinion, what they are not good for, how they are distinct from PREMs. 4 examples from Europe. This is not a rigorous review or something like this. I try to find some examples on PREMs from Europe that I consider worth reporting on. I have to say that overall, I didn't find that many examples that may serve as an example to others, but this is something that we can discuss, of course. Then some words on actionability, so what can you do with PREMs once you collected them? And as a conclusion, whether we are there yet and should we engage in PREM collection at all, or in what way. So the German Cancer Society is committed to evidence-based medicine. That means that we intend to implement evidence into practice. We do this through guidelines. So the German Cancer Society runs its own guideline program. So we have guidelines for all the major cancers. And out of these guidelines, we derive quality indicators. And these quality indicators then are the basis of a certification system that we run for all major cancers. This is similar but different from what the OECI does. But you can see that there is like a code of law, that's the guideline. Then we develop the requirements, collect the data via QIs and other standards, and then we do annual reports. So these are clinical quality indicators reports for all the different cancer types. This example is lung cancer. And they look all the same, basically. So you have, these are funnel plots. Oftentimes we don't have funnel plots, but we have caterpillar plots. Typically they look like this, that you have a dot for each center, and then they can compare each other, yeah, benchmarking, that's what it is. And for some cancers, so for prostate and for colorectal cancers, we also collect PREMs data. Okay, so I say some more words on this later, because this may be important also for a PREMs systematic. We don't collect PREMs. And of course, like you, OECI might consider collecting PREMs in your centers. We, as German Cancer Society, might also consider PREMs, collecting PREMs in our centers. We're not sure yet if we're going to do this or not. So some background on me, only a few words. It's not to brag with what I did in the past, but it's just to explain maybe why Cinzia invited me to this conference. I'm the head of a small but growing health services research at the German Cancer Society. We're currently more into PREMs, as I said, prostate cancer, colorectal cancer, prostate cancer. We survey 10,000 patients, prostate cancer patients every year from over 100 centers. Okay, so just to have an impression of how many patients we are dealing with here. Much less in colorectal cancer centers. You can read all this if you want. Before I joined the German Cancer Society, I worked for the University of Cologne, and there I was in charge of serving breast cancer patients in one state of Germany, so North Rhine-Westphalia, size of Netherlands, more or less. And there we surveyed 3,000 through 5,000 patients every year, PREMs. Okay, so I have some experience, but that knowledge is kind of dated, of course. And we published lots of papers then, and this system is still going on. So we still have the data, we're still collecting these PREMs at the University of Cologne. I'm coming back to this later. So PREMs, a brief systematic, we heard a definition already. This is one that I like. It's from Kingsley and Patel, 2017. PREMs gather information on patients' views of the experience, of course, whilst receiving care. They are an indicator of the quality of patient care, although they do not measure it directly. So this is important. PREMs are most commonly in the form of questionnaires. There are other possibilities to collect PREMs, of course, but that's still the standard. So now, what are PREMs good for? I don't know if you, Sabina, elaborated on this. From my opinion, there are 3 reasons to collect PREMs. One is benchmarking, so provider comparison typically. Unless there is like an external standard that you want to fulfill, then you may do this on your own institution. Then the second thing is changes over time. If you want to look at changes over time, it may be enough to only collect PREMs in one institution, because then your comparison group is the historical control group, or groups, so to speak. And the third, and probably most complicated purpose is health system performance assessment. So not only comparing single providers, hospitals or so, but to collect whole healthcare systems. And once you did this, the real work only begins, because then you have to work with the data, see how can we put this into some working quality management scheme, PDCR cycles and so on. But these are the 3, from my opinion, major purposes of PREMs. And what is not less important, where the PREMs that you want to collect come from. And again, my opinion, I'd say 3 sources of ideas of why to collect PREMs and what PREMs to collect. Is it in the guideline? If there's something in the guideline that can be assessed through patient experience surveys, then that's a good reason to collect these, unless there's another way to collect these better, of course. Then is there a strong expert opinion that suggests that some PREMs should be collected? Experts always include patients, of course. And the third one is it in the law? So if something's in the law that can't be collected otherwise, then you may consider collecting this via PREMs. I will show you an example from Germany on a later slide. And then PREMs, as distinct as PREMs as they are. PREMs are not PROMs. That's again Kingsley and Patel, 2017. In contrast to PROMs, PREMs do not look at the outcomes of care, but the impact of the process of the care on the patient's experience. For example, communication, timeliness of assistance. That's very similar to what Sabina presented. And of course, these definitions are more or less the same overall. This again is from the prostate cancer PROM program that we run. And I just show you that to illustrate that what I just said are good reasons for PREMs, are of course also good reasons for PROM collection. So benchmarking here, every dot with the antennas around is one center, and each center in this case can see how it compares to the other centers. The further right you are, the better your patient health is. Here it is incontinence. Incontinence, prostate cancer, everybody knows that's important after surgery. No reason to discuss, of course. So this is why this works so well. We don't have to convince many people to do this. The second thing is changes over time. Again, no-brainer, you want to see if you improve over time. If you don't improve over time, then what can we do? Or is this, okay, and then there come methodological aspects, whether the measurement is good and so on. But these are details. And the third thing, and this is possible for prostate cancer data as well, is the international comparison. In this case, a comparison of 15 countries. Spain is among them, and this paper was just recently published, and Olat's Karin, who's sitting there, was also part of it, where we compared data from Germany with 7 other centers, and you see that, for example, Austria does best. They have many fewer centers in the sample, but at least they have enough patients included to have their results shown here. So these are the 3 purposes of PREM collection, in my opinion, and they are similar for PROMS collection. If you don't arrive in doing this for PREMs, or at least one of this, then there may be something wrong. 4 examples from Europe. First one, NHS England. I love this example, even though I'm not at all involved in it, and I haven't read too much into the details, but I'd say if you want to have an example of how to collect PREMs, then this may be one. So this is done by the Picker Institute. Picker does not only collect PREMs in England, of course, but elsewhere as well. And they state a clear purpose to monitor national progress on experience of cancer care. So this is more the direction of changes over time, improvement. They include tons of patients, 60,000 answered the questionnaire only in 2022 from 133 trusts. Trusts seem to be what they call hospitals. And the response rate of 53%, that's quite good, I'd say. They do this since 2010 annually, so they can compare over time. They can depict differences between hospitals, and they can adjust. I don't know for what they adjust, but they do adjust for case mix. And they can, of course, depict changes over time. A sample item is where the results of the tests explained in a way you could understand, and then yes, completely yes to some extent. No, I didn't understand the explanation. I didn't have an explanation, but would have liked one. So this is how they do it. This is how they present it. This is just from their PDF report, but they have like really tons of different things you can look at their website. So I clearly say this is an example. Another thing that we are waiting for is Paris. I don't know if anyone here is involved in Paris. He or she might elaborate on this better, but this has long been expected. This is on chronic conditions in general, not only cancers, but cancers are included as far as I understood. The purpose was to measure patient-reported experience measure, which measure how patients experienced health care and refers to practical aspects of care, such as care coordination, waiting times, and provider-patient communication. So what we typically do with PREMs, clearly defined inclusion criteria, people aged 45 and older with chronic conditions and so on. Since when I read that this is going to start, or has started in 2023, the results, I couldn't find the results. Maybe they are somewhere, but not on the website. But it is done in 20 countries, so that's quite a thing. So if you want to compare countries, and if you want to see how this can be done, this may certainly be a source. Between providers, as I understand, will also be possible. Changes over time, not yet, but I believe that this is not something that will be done only once. Sample item is your healthcare organized in a way that works for you? And then yes, definitely yes to some extent. No, not really. No, definitely not sure. North Rhine-Westphalian breast cancer centers, Germany. Purpose is accompanying health services research. That's what in the book, that's probably nothing that anyone can understand what's meant by this. Basically, it's part of certification for the North Rhine-Westphalian breast centers, different from what the German Cancer Society does. And the purpose is quality assurance in general and benchmarking. Patients are the adult breast cancer patient population from 50 centers in the one state of Germany, North Rhine-Westphalia. every year from February through July, and they include between 4,000 and 5,000 patients. And the centers who want to be accredited according to this scheme, they are demanded to participate in the survey. Without survey, no certificate. As simple as that. And that's why it works so well, of course. Yeah, if you force them, then they will do. Since when? Since 2006. I was in charge of this from 2008 through 2014, and it still lives. Differences between hospitals can be depicted, also changes over time. Sample item is, this is not originally from this survey, but it is much older, but has been in the survey since 2006. The doctors gave me a full explanation of my symptoms and treatment on an agree-disagree scale. We can discuss this, but okay, that's how it is. Here an example of the advantages of following something for such a long time, even if the item that you ask are not perfect anymore, but still you can see, you can track changes. So something happened in 2011. That's what you can easily see, something happened. This is patient activation and participation in decision-making. So this is part of a larger shared decision-making concept that is depicted here. Then, last example, Institute for Quality and Transparency in Healthcare Germany, also prostate cancer, cross-sector quality assurance procedure for the quality of diagnosis, counseling, and treatment of localized prostate cancer from the patient's perspective. Hasn't started yet, but will, once it's started, done by all providers, approximately 200 patients in each practice or hospital. Quite a thing. It's under construction since 2011, but we expect the first, no joke, we expect the first patient to be probably enrolled in 2026 or so. Once this has started, this will impress many, I can tell you. And so differences between hospitals will be depictable, changes over time, of course. It all will be one day, but what I want to show you here is the sample items. Did a doctor talk to you before the operation about the following side effects that might occur as a result of the operation? Please tick one box. Uncontrolled loss of urine, incontinence, yes, no, don't remember. Impotence, erectile dysfunction, and the same for shortening of penis, difficulty or pain when urinating. And where does this come from? Directly from the guideline, okay? So this is a grade A level of evidence for recommendation from the guideline. During the medical consultation, the patient should be informed about all relevant treatment options described in this guideline, their prospects of success and their possible effects, in particular the effects of his physical appearance, sex life, impotence, his urinary and fecal control, incontinence, and so on. So this is something, if you don't do this, if you don't consult your patient on this, then you do something wrong. It's in the guideline. And it's not even in the guideline, it's also in the law. So paragraph 630, Article 2, Law for the Improvement of Patients' Right, the practitioner is obliged to inform the patient in an understandable manner and so on. So this is something that has a legal basis in the real law and also in the guideline. So this is very strong, a very strong reason to collect such PREMs. Okay, it's not only because someone had the idea it would be nice to find out how good the food is, but this is done because it's in the law. Actionability, of course, I make this very brief because this is clear to everyone. I mean, once you collect PREMs, in advance, of course, you need to think about what can you do with it. Major purpose is monitor progress, FDCA, FDAC, you know, the circle, FDCA, yes, thank you. Exactly, some kind of quality management. Without that, don't engage in collecting, of course. Limitations, Sabina mentioned some of them. Are the right persons addressed? Do we follow up really? Do we take it seriously as in North Rhine-Westphalia, where you are demanded to do this, otherwise you don't get the certificate, is one way to do this. Are sanctions in place? Are there? If they are, then people will comply, typically. Skip this. But now the evidence for improving care with PREMs. I would say as yet is rather slim. That doesn't mean that it's not helping, but I haven't found any strong studies showing that PREMs improve care over time. Designs would be costly and long-term. If we want to engage in something like this, we have to be sure that this is the case. Are we there yet? Okay, no, we are not. There are some good practices, not too many, I would say. Sometimes it's not totally clear, not in what I presented here, but in other, oftentimes smaller projects. It's not always clear what is really done, if it can be achieved with what is done, if it is sustainable. That's important. If you only do this once, that probably doesn't contribute to care improvement. Should we engage in PREM collection? This is a question maybe for the OECI. It's also a question for the German Cancer Society. We haven't done so yet. I'd say the strongest reason to collect PREMs is if it is in the guideline, something that can only be assessed by the patients, not otherwise, then it's useful to do this. If it is a legal requirement, then it is a strong argument for it. Or if there's strong expert consensus. But it needs to be methodologically sound, and the last thing that I would say is that we should not engage in collecting PREMs as a substitute for QIs quality indicators that we are really interested in, because sometimes this is the lower hanging fruit, but when it's not really thought through and so on, we should not do this, my opinion. Because there may be other ways to spend money. Thank you.
Thank you very much, Christopher. Are there any questions to Christopher? Yes, here. Thank you.
Thank you very much, Christopher and Sabina, for the wonderful presentations. We are currently developing a PREM for cancer care. It's the first one in the country. We do have one for shared decision-making, but it's a generic one. And one of the things that we found so far in the process of developing this is that the time when you will apply the PREM, it's quite debatable, probably. So I wonder, in your experience in the journey of cancer, where would you place key points for people to measure experience?
So I'm not sure if I'm the best person to ask this. So I don't know the literature on so my idea would be as soon after the event took place as possible, maybe not the same day, maybe not one day later, but relatively soon afterwards. And in North Rhine-Westphalia is that we send out the questionnaire 1 through 4 weeks after discharge. So, and yeah, I'm not sure. Sabina, maybe you know if there's some reliable, literature on this.
Well, I may present something about participation of patients in the development of PREMs later on. I would say ask your patients after a shared decision-making moment in their healthcare process when they want to share their experiences. And if you ask 5, you might collect 5 good answers. Also, maybe 5 very different answers, but yeah.
Just to add, in our previous experiences, we developed the questionnaires, as said by the colleague, with professionals and patients. But usually you have to map your pathway and identify the right moment. There are several guidelines and papers on this, but you have to make it, let's say, local, valid, I think. So this is the most important suggestion I can do.
Other questions? probably we can proceed and maybe we have further questions later.